Advice Daily Show. How are you? I'm Dr. Lindsay Huey, lead faculty for extremity management, along with Eric Chacones. Welcome to Clinical Tuesday. I am again delighted to be here with you on Clinical Tuesday. It's my favorite day of the week, and so thanks for joining me today. So we're going to talk today about neurodynamic fitness and excellence as it pertains to extremity management. And what do I mean when I say neurodynamics? So it's the ability of each of us, each human, to be able to engage with their world. So in ADLs, IADLs, ANLs, my favorite, and then the ability to engage in normal life, but then those things that happen not so expected, where you have to react quickly or take on acute workload more quickly or more intensely. So think about the older adult who trips on the lip of a carpet and has to take a quick step strategy to avoid falling. Or the mom that is constantly picking up her 3-year-old as he runs into a crashing wave with no fear, which was me last week with my son. Or the CrossFit athlete or functional fitness athlete, whatever you're calling it these days, who increases their weight for deadlifts or lifts kind of funky. Is their system neurodynamically ready to take on those quick loads? So our neurodynamic system needs to have flexibility to move quickly and react. And I think as PTs, we are not impacting this space as well as we can. So I want to propose a structure to promote neurodynamic fitness in extremity, using the REMOM. But before we get to that structure that I use often in the clinic and suggest for increasing resilience for neurodynamics, I just want to review a little bit about what we know about neuromobilization and its benefits. So you typically think of using neuromobilizations when you're thinking about a cervical radiculopathy or a lumbar radiculopathy. And so I think we usually only use neuromobilizations, or we tend to use them just in these conditions and as an adjunct to our manual therapy, whether it's lateral glides for the cervical spine, and then we do some on-off median nerve gliders or sliders, depending on what you call it, or some lumbar gapping or PA mobilizations, and then we do our sciatic nerve glide. But I really think we can impact extremity management by using it in our overuse conditions like carpal tunnel syndrome, tarsal tunnel syndrome, even your decurved veins. And the thing is, we don't know a lot about it in the research. So a 2017 JOSPT systematic review looked at the effectiveness of neuromobilization. This is by Basson et al., and I can post this for you guys later, or for you humans. I'm trying to get away from saying you guys. I will post this, but it looks at the effects of neuromobilization, and again, the effects on pain, disability, and function are seen more studied in that lumbar or cervical radiculopathy and less studied in those overuse conditions. And in this systematic review, and as in most systematic reviews, dosage, there's this big paucity, right? We don't know enough to say this is the preferred dosage. And so it creates this gray area. But the gray area is what really excites me. It's the area I love to treat in, and that we have the opportunity to have the greatest impact as PTs because we can explore it and we can dose based on the individual before us. But I think when we see gray, we tend to shy away. And that's why we're still in that box of really only using it in radiculopathies. But today I want to challenge you to think past that and keep in mind the effects of what does neuromobilization do. And in that systematic review that I referenced, it talks about the established benefits of increasing intraneural nutrition, decreasing intraneural edema, helping with activation, helping improve homeostasis, not only in the nerve, along the nerve, and then around the nerve. So in that musculoskeletal system, helping with improved activation. I think we always think of it as helping decrease pain, but there's opportunity to think about it and use neurodynamic, not only testing, but treatment outside the box. And pretty much, I think every time you'll see me on here on Clinical Tuesday, I'm going to be talking about some gray area because, again, that's what excites me. And that's where I think we have this opportunity to have the greatest impact as PTs when we explore it. So without further ado, let's get to the actual remom that we're here to talk about. And so a remom is every minute on the minute, a rehab EMOM. Thanks to Dr. Bitch Babcock for introducing ICE to this concept and to me, because it's really changed my practice. And I'll use it anywhere from the 4-year-old to the 99-year-old. And so don't think of this exclusively for the fitness athlete. That is what I tend to treat. You can see here I'm in my clinic at Drive PT, which is out of a CrossFit gym, but I see a range of all ages, and I will use this for a range of all ages. What I'd like to suggest is a structure that we use. So either a 9 to 12 minute EMOM, which would mean 3 to 4 rounds every minute on the minute of doing one of the 3 of the following. The first thing, picking some cardiovascular activity for the first minute to really perfuse the tissue. So whether it's upper body or lower body, you'll pick. And I'll show you some examples or tell you some examples after this. The second thing is pick a neuromobilization. And that could be, they're interchangeable in words, whether it's a slider or glider or a tensioner. And when we think of slider, glider, we're thinking the more irritable, high severity, whereas a tensioner, it's more chronic population and less irritability. So keep that in mind when you're thinking of your dosage. But again, that second thing will be a neuromobilization. And then that third thing that you'll pick in the remom is a loading activity, whether it's a loaded mobilization or a loaded strength activity or even an activation exercise, so that you have 3 great things to work on for 3 to 4 rounds that are constantly bringing blood flow to that area, perfusing tissue, getting that chemical junk away from the area. And so I'm going to give you 2 specific examples that I like to use and then kind of challenge you to make up your own. So carpal tunnel syndrome. Commonly, you're going to get those 3 digits, pain, numbness, tingling, and you'll also see some coinciding wrist and elbow deficits, some hypomobility. Usually it's some secondary complications of guarding or just some workstation setup, depending on what the cause is. And that'll be individualized to your patient. But just think about this person in your head. So for this patient, I'm going to use 1 minute. This probably will do a 12-minute, maybe 9-minute to start, but we'll say my patient's been here a little while. So 12 minutes. The first minute's going to be UBE. The second minute is going to be a median nerve, some median nerve flossing, whatever you call it, gliding, flossing, but some on-off to help with intraneural nutrition. And then we're going to do some loaded wrist mobilization. So picture, if we want to be more aggressive, quadruped and just rocking back and forth. And that will help not only the wrist joint, but also the elbow. And then you'll repeat that. So 3 to 4 rounds. Just one more thing to note, if someone's too highly irritable to be in quadruped, you could also just do standard loaded for wrist mobilization. How cool and how much more interesting to come to a clinic, check in with your patient, give them a remom to start as a warm-up, rather than say, hey, Mrs. Jones, go get on the UBE for 5 to 10 minutes, 5 minutes forwards, 5 minutes backwards, and then I'll see you after that. But how great to really prep those tissues for manual therapy. So when they get done, they come right to you, and then whatever kind of deficits are still lingering or exercises where you need to be right watching them the whole time, you can spend time and focus on that. This is one example for the upper extremity. Now let's think another example of a remom in the lower extremity. Someone with tarsal tunnel syndrome. They get that numbness, radiating symptoms along down that posterior tibialis, maybe a little bit into the foot as well. So this is the patient we're thinking of. A lot of times in our runners this happens. So this patient, my remom might be structured or look like treadmill. And depending on the stage of severity and depending on their severity and irritability, I might have them walk at a moderate intensity. And when we're saying moderate intensity, think about that RPE, like 4 to 6. We want to get that heart rate up. We want to get blood flow and perfusion to that tissue. So walk on the treadmill. The second one would be a sciatic nerve glide with a nerve bias into dorsiflexion and eversion, right? So we get that tibial nerve on off and getting that intraneural nutrition to help with those symptoms. And then do a loaded exercise where I have them do a bilateral heel raise with that tennis or lacrosse ball squeezed by the calcaneus. So then we follow up with load. And some qualifiers or disclaimers would be, I don't just send my patient right into this, right? I'm going to go through each movement. I'm going to make sure the patient understands what the purpose is, that they're doing it with good form, and then monitoring their response to make sure that they're not flaring up, right? Qualifiers for the neural mobilization, we're going to expect symptoms to come on and intensify, but then go down. They should get better. When you're doing the cardiovascular activity, it should just feel good. It shouldn't be painful. So giving these qualifiers before you have someone start. But I find this to be a much more effective and engaging way to challenge neurodynamics, make it interesting. And again, I can't emphasize that blood flow piece enough to help with intraneural nutrition. And then it's also a challenge. It's not just walk on the treadmill, Mrs. Jones. Okay, now let's go to the plinth, lay down. Let's do some sciatic nerve glides. That is boring. So let's be more engaging and let's challenge the nervous system. And, those are my two examples, but I challenge you either today or sometime this week to apply this structure, so a cardio, a neural mobilization, and some kind of loader activation to one of your patients and see the awesome effects that it can have. Really watch your patient, monitor them, right? The nervous system can sometimes be sensitive. And, this is ice. So we're not only thinking about what we're doing manually, but we're having psychologically informed practice, right? We're thinking about the whole human before us. Think about the stressors they're going through that day. We're in a time of health crisis, not only for our internal health, but our emotional, spiritual health with this war on racism that's happening. So we need to remember to consider the whole person and make our dosage accordingly. The remom is beautiful because maybe we don't use the whole minute. Maybe you tell the patient, maybe they just had a really stressful, bad day or are just emotionally charged from everything that's going on. Tell them to do 30 seconds of work of the neural mobilization, then have a 30-second rest break before they start the next minute. So I appreciate your time today and your openness to learn a new structure for dosage for neurodynamics. So cheers and happy Tuesday.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.